Hi, I'm Marina Kurian, and it's my pleasure to work on the Trailblazer project and to, in particular, to interview Dr. Gerald Fried. Jerry, I've been such a fan of your work for years. You know, you've made such a mark on education and metrics to improve our training. Since I was a fellow, I've been following everything that you've done with great interest, and honestly, if there's something on surgical education that's worthwhile reading, usually your group has published it. And thank you for agreeing. I know you don't want to say that's true, but I'm telling you it's true. I've found your work really fascinating. But one of the things that came out of the Trailblazer project is that, you know, you guys who train fellows, and then they go on to train fellows. So you actually have great fellows or great grandfellows, right?
Grandfellows, that's it. Yeah.
And what we're finding is that when people discuss what is a particular technique, especially for foregut, that it can be traced back to a Trailblazer, and that's where we are.
Well, thank you, Marina. It's first of all, it's a huge honor to be included among the people that are considered trailblazers in foregut surgery. I think one of the remarkable things, like many people, I got involved in laparoscopy relatively early on and asked the question, where do we go from here? We did gallbladder surgery, we did hernia surgery, and we were looking for some other opportunity to extend that. And the opportunity seemed to direct us towards the foregut because the cost of the incision in the upper abdomen seemed to be particularly high. So we had this tool, and we were looking for an opportunity to apply that in a constructive way to really benefit the patient. So a lot of the original procedures were they're almost made up as we went along. Mm-hmm. We were presented, residents would come to us with a challenge and say, can you do this laparoscopically? Can you do this laparoscopically? And we tried to create a solution to a problem that we felt would really benefit the patient because we would save them the injury of an upper abdominal incision. So I think that was the most exciting time because it wasn't doing something in a routine way. It was really coming up with an innovative solution and often thinking on our feet to solve problems. It's been a wonderful joy. And as you said, I think beyond that, the opportunity to then take the next generation of people who wanted to focus on a particular area and mentor them and help them get the skills in order to take the field further. In the early days of laparoscopy, the remarkable thing was we went back from being a general surgeon that had focused in a specific area to a true general surgeon. Mm-hmm. I was doing kidney operations. I was doing adrenals. I was working with the gynecologists who were way ahead of us in doing laparoscopy in earlier years, but didn't develop the skills and just try to use this tool in a broad sense. And then all of a sudden, we realized that we had to focus, and then our next generation became specialists in particular areas like the foregut.
So let's talk about specifically, let's say, a fundoplication, right? Yeah. I want to sort of look at how you trained and when you got done after your chief resident year, and then track forward to what changes you may have made as a junior attending, and then as more senior as well, training your fellows. So just to sort of follow, unless your technique has been the same, and which is completely reasonable, because sometimes you learn how to do something, and if you do it the same way every time, the reproducibility is there, and of course everything becomes more effective. But there have been changes certainly in how we address fundoplication, and I'd love to hear what your particular journey has been.
So I trained in the open era, so I did open fundoplications relatively infrequently because we had medications that worked reasonably well, and the operation did not have a particularly good reputation. And the gastroenterologists, who generally were our source of the patients, thought about fundoplication as kind of the last resort. So really, although I did them in my practice, I would say maybe I did 3 or 4 a year, and I had a pretty broad GI practice. So I wasn't a foregut surgeon in terms of my training, except ulcer surgery. And believe it or not, I was an ulcer surgeon. I did 150 ulcer procedures my first year in practice. So
Wow.
to put things into perspective, and of course, ulcer surgery went away, but my comfort at the hiatus was there because I did so many vagotomies and was used to, getting around the esophagus. I was comfortable in that area. When laparoscopy came, we, as I said, we wanted to think of the next opportunity after lap chole, and we thought about the foregut. So originally, we would have a group of us that would actually meet to talk about how to do ulcer surgery by laparoscopy. But then, as we were coming up with the solution, the disease went away, and so fundoplication seemed to be the ideal next thing. So I started to try to do the operation the same way as I had done it open, but I realized, I was tying off the short gastric vessels when I did it open. It was not very easy to tie the short gastric vessels by laparoscopy. So I think we made a lot of at least I made a lot of compromises in the way I mobilized the fundus, because it was technically such a challenge. Didn't have energy sources. We had clips that originally were individual. They would fall off. They would scissor, and then you get into trouble. So I don't think I started by doing the operation as well as I did open. Eventually, obviously the technology came out, but for me, the seminal opportunity was in 1995. I was a James IV traveler, and I spent 6 weeks traveling and visiting centers of foregut excellence around the world. So I went to Hong Kong, I went to 3 different cities in Australia, and I went to San Francisco, Seattle, and USC in LA. And I had a chance to spend 6 weeks watching really outstanding people do this operation, and each of them had their own nuances. And I incorporated a lot of the things that I saw in these individual programs into my own practice. And after that 6 weeks, my ability to do this operation well increased like tenfold. It was a dramatic opportunity, and it really helped me move that forward. So then I think I really understood the principles of the operation, and tried to take the best practices from de Meester, from Pellegrini, from Larry Way, from Marco Patti, etc. The great group in Australia that did a lot of
Watson
work.
and
Les Nathanson.
Les Nathanson, yeah.
And they were studying it also. They were doing a lot of randomized trials, looking at things, routine short gastric division, partial wraps versus total wraps. Really, I think the Australians studied the subject extremely well. And so I over the time, I've evolved my technique. And increasingly in recent years, I've been doing more and more toupees, and have been very, very happy with the results of the toupee. So right now, if the operation, obviously I study the patients and try to understand their motility, their physiology, but I would say that we probably do about 80% toupees and 20% like 360-degree wraps. And we study our patients, we bring them back for routine 24-hour pH studies and motility studies, endoscopy and barium studies, so that we have an opportunity to constantly look at how we could improve our outcomes.
You guys have to be super charming in Canada, get your patients to come back for the pH and the post-op manometry, because that is so difficult.
We we just explain to them that this is part of the process, and they generally accept that.
So let's do some technical discussion then.
Yep.
So always crural repair, what size bougie, and if we're talking specifically about the Nissen, when did you go from the classic to the floppy?
Always
start with
close.
crural repair, yeah.
Always close the crural, because I think that in the process of dissection and mobilization of the esophagus up into the chest, then you've pretty much opened up the hiatus. So I think that I don't think I always put a few stitches in the crura. I always use a bougie. I put it down myself at the beginning of the case. So before I scrub, I put it into the mid-esophagus. So it's down through the upper part where I find the anesthesiologists often struggle under the drapes to place it, and I get a little anxious about it.
That's actually quite clever.
So I'll position it because you don't want it through the hiatus, because it doesn't allow the esophagus to be easily retracted and mobilized. But position maybe about 10, 15 centimeters above the LES, and then it's very easy for them to pass it through. I've always done a floppy Nissen, so usually around a 56 bougie. It's a smaller, woman, maybe a 54, 52, but usually 56.
And then you say you're doing a lot more toupees.
Yes.
Does it matter if it's a very large para versus a smaller? Does the size of your paraesophageal hernia really affect your decision to do one more than the other? And then the other question I have is about manometry. Ideally, I like to get manometry in everyone that I operate on. However, sometimes it's just impossible. So in those patients, I will offer them a partial wrap.
Right.
And so that's really the question: is do you do manometry in everyone?
We do. So first of all, we do manometry on all our routine Nissens that we're doing for GERD, but we don't do it for most of the large paras. And in fact, that's the largest part of our practice now. We probably do
because of an aging population, or
yes, but also because patients that have their reflux reasonably well controlled on medication, and the medication is paid for in our healthcare system, they really don't elect to have anti-reflux surgery. And those are the ones that do the best with the anti-reflux, people that respond to PPIs. So I would say we do 2/3 of our operations are for paras. And so we do quite a few. I'd say we probably do 100 paras a year. Usually they're large ones. And they're hard to study well and to get accurate, reliable motility. So, and often they're done I wouldn't say in an emergency, but in a more urgent fashion. And in our healthcare system, sometimes it just takes a while to get a motility study done. So we don't routinely do the large paras. We routinely do the regular Nissens with a small sliding hernia. So that's one of the reasons why we've done more and more partial wraps. If it's a very elderly patient, we will do a door. But I would say most of our patients we're doing toupees on, and they've done very well. It seems to have been the best compromise between a good good improvement, good control of reflux, but we're not getting the bloating and dysphagia that we were seeing with the Nissens, with a lot of dissection in the mediastinum. They've done well. So to me, we've come to an area that we're quite happy with in our group. So
I think
we'll
that's
stay
great.
with that.
One thing that I had been saying, and SAGES has the Masters in Foregut Facebook group, and one of the things we were talking about, because everyone's like Nissen, Nissen, Nissen. I made a comment a while back. I was like, there's a lot more toupee out there than you know, because there are a lot of patients that you feel might have an issue with the Nissen, et cetera, and then like you. When you look at the data coming out of Australia, and I'm very familiar with, I just gave a talk on that, so this is why when you were like, they're studying it, they certainly are, and they have great research that the toupee does give comparable results with less dysphagia
Right.
and gas bloat. So,
and good patient satisfaction. And their data is now out for quite a long
right,
time.
over 10
Yeah.
years they have, and they have some that's 20 years.
Yeah. So their DOOR data, which originally looked good, seems to deteriorate over time, and you get a lot of recurrent reflux. But their Toupet data, and that's been our experience. We have not, and now we're not maybe out as far as we need to be, but we're very happy with the quality of life and a good control of their reflux.
Now, you said that early on you didn't divide the short gastrics.
Correct.
Right? Actually, from also the Australian
Yes.
data, they have data that shows that there's actually more bloating that
Yes.
occurs with divisions of the short gastrics.
Correct.
So, what's your impression of that, and does that affect your practice?
So I would say I use their data to rationalize my practice. So they showed that you didn't have to, and I remember having this conversation with John Hunter and with Lee, and they said they really didn't believe it, and I think part of it was that the average person out there, if you wanted to standardize the operation and to teach it in a reproducible way, it's much easier to do it if you divide the short gastrics.
Right.
When we were not dividing the short gastric, we did still spend a lot of time mobilizing the fundus from all its other attachments, posteriorly, etc., to the left hemidiaphragm. So you really could, you could get a reasonable repair. And I think the results weren't terrible, but I feel now it's easy technically to divide the short gastrics. And I feel that when I do a Nissen, it is much more, the fundus is much more mobile, certainly, if you do it. But I still was getting, bloating, gas bloat. Dysphagia, tended to be temporary, but the gas bloat persisted, and a lot of patients were actually unhappy with that. And that's really the main reason why we went to the Toupet. And with the Toupet, we're getting less early dysphagia, but certainly less longer-term gas bloat. And so the patients seem to be much happier with it. So right now, I'm in a comfort zone. I've been able to get that operation standardized. At the beginning, there was some concern about the geometry, some twisting, but I think now we've got that. We do a posterior gastropexy to hold the fundus, to the right of the esophagus comfortably, so it doesn't want to twist back.
I was
and
going to
rotate
ask
that.
about that, because a lot of times when you go back for any kind of revision after a Nissen, and even when you're doing the Toupet and you've mobilized the short gastrics, you see that the stomach just wants to
Go
bring
back
it
where it
back.
was, yeah,
Right.
yeah.
And it is kind of hard to keep it in position. So you're taking a bite to the pre-aortic fascia, or
to the posterior, to the crest, to the area of the cranial repair, and so it maintains the orientation, and it really lines things up very well. So you put 1 or 2 stitches posteriorly, and it takes all the tension off the stitches to the esophagus, which you don't want to have. You don't want those stitches to pull through. And then we bring the fundus to just basically on either side of the anterior vagus. So we leave a little strip around the vagus, which is uncovered.
right.
And that seems to work quite well now.
I feel like we could change this to controversies in fundoplication. I want to ask you about use
Yeah.
of mesh or not use of mesh, and use of mesh in a primary or use of mesh in a recurrence, and what type of mesh.
So we went through a phase of using, first of all, I didn't want to use mesh. But I got swayed a little bit by a randomized control trial, which seemed to show a substantial difference in early results.
Early.
And so I started to use the mesh. I said, listen, if we're teaching evidence-based practice and the evidence suggests that it's better, we should use mesh. But I never liked using mesh. And we used biologic mesh. After the long-term data came out, I stopped using mesh because That was my bias anyways. We've looked at our recurrence rate. It's much easier to follow patients, I would think, in Canada than probably here.
Yeah.
So it's been easier to keep track. And our long-term recurrence rate's around 22%, which is not bad. I mean, I think
Right.
it's as good as most places without using mesh. So we don't use mesh, and we don't use mesh for most recurrences because it's often not the tightness. It's not that the sutures dehiss. It's that the fundus actually goes up anterior to the esophagus through a relatively tight opening, and frequently you have to actually open up the hiatus to pull the fundus down because it incarcerates up in the chest. So I don't think that's the solution to the problem. I think it's really the mobilization of the esophagus and make sure that you don't have a short esophagus. So I don't use mesh unless I just the crurer just tear. Occasionally you'll get a case like that. So it'll be a last resort. It's not my go-to practice.
All right, Jerry, so just to conclude, I want some final thoughts, but I also want to know where you see foregut going in the future.
Well, if I were giving advice to someone who's starting their practice now, the strongest advice I would say is really get good at the flexible endoscope. I think that the solution to a lot of the problems that we're currently treating surgically with laparoscopy or robotics will go to some sort of flexible endoscopic platform. And I think if you look at the advent of the POEM procedure, of resection of intraluminal tumors, I think that it's a remarkable platform, and it'll only get better. I think it will extend into the bariatrics field. And I don't know, exactly how we're going to solve the reflux problem. Certainly the large hiatal hernias will always be managed surgically. But if we're looking forward and you want to develop expertise that's going to prepare you to be a foregut surgeon that will really move the field forward, I would embrace flexible endoscopy. And that's the nice thing about SAGES. It really has encouraged people to be innovative with the flexible endoscope, and as Dr. Ponsky said today, to be endoscopic surgeons.
Right.
And I think that would be my pearl of advice that I would give people.
Okay. Well, that's it for us, SAGES 2019, and it was my great honor and privilege to interview Jerry Freed, our past president of SAGES. Thank you.
Thank you, Marina, and it's an honor for me to be included among the people that are